Thank you, dear Chairman and dear all the audience. It's my great honor to present my topic here. It's hard to answer this question now, I think, because we don't have enough evidence to show the whether lot CIT is better than BiVP CIT. So for the lot CIT, we know that it's plus LBB pacing together with CS lead LV pacing. So for the lot CIT, let's introduce CSP first. When we code CSP in clinical practice, it's always like LBB pacing plus or his bundle pacing. Because left bundle branch pacing is feasible and safe, then his bundle pacing. Now we do most of the CSP cases is LBB pacing. This slide, I think Dr. Wang has already showed us that it is from these slides we know for narrow QRS patient, LBB pacing or his bundle pacing can achieve better electrical synchrony than BiVP pacing, because BiVP have a very wide QRS complex. But for LBBB cases, I think both BiVP or CSP can narrow QRS duration. But for his bundle pacing, it has a complete synchrony of both RV or LV. But for left bundle branch pacing, we just have partial, synchrony. It can achieve complete LV synchrony, but the RV will have, desynchrony because we have a QRS duration of RBBB shape in LBB pacing. But if we have an IVCD case, the story is totally different. Neither BiVP pacing or his bundle pacing or LB pacing can achieve a very complete electrical synchrony. Maybe they just can improve somewhat of the electrical synchrony than the intrinsic IVCD morphology of this QRS complex. And let's come to see the guideline. 2023 HIS CPP guideline also have the similar indication in non-LBBB case with heart failure. For BiVP CRT, the indication class is class 2A or 2B, but for CSP, it's just 2B. That means we don't have very enough result, better result to show that if we do BiVP CRT or CSP, we can have a better clinical result in this heart failure patient. Here is another paper to show that using LBB area pacing for the CRT in all kinds of CRT candidates, like LBBB case or RBBB or PICM or IVCD. From the baseline table, we can see that for IVCD case, LBB pacing success rate is quite lower than the LBBB cases. And LBBB shape of the morphology at baseline can predict better electrical graphic response than the non-LBBB morphology. This is what we also know from the previous studies. So here is a slide to show maybe there's a different mechanism of LBBB and IVCD. From this figure, we can see if we have a true LBBB morphology of a case, that means it's a proximal block of the LBB. So if we can paste just beyond this block, because the distal conduction system is healthy. So we can have a very good QRS duration with a narrow QRS complex using LBB pacing. So when we have LBB case, maybe LBB pacing only is enough to correct this LBB. No need for BiVP or no need for a lot CRT. Because you see from these slides, if we have a very healthy distal conduction system, we achieved LBB capture, then we can have a very fast conduction system capture. So just add another LV lead from the epicardial. Epicardial is not useful, I mean, because the conduction system always have a very fast activation then from the myocardium. But if we have an IVCD case, the things is totally different. Maybe we will have different mechanism of this IVCD. Maybe we will have a proximal block plus a distal block. Or sometimes we will have a very diffuse block, or just distal block. When we have this different situation, LBB pacing or conduction system pacing may just can do very little or some kind of synchrony. It's not quite similar to the LBB cases. At these three conditions, maybe LBB only may not enough, I mean, to correct all these IVCD. So at this situation, maybe lot will be better, have better effective clinical outcome than the LBB only. But sometimes things seems like not so similar enough, because we can see if we have a very diffused block, LBB pacing only cannot achieve better complete synchrony. Lot may also not can achieve better synchrony. Sometimes we just maybe try to plus another lead, another CS lead, to try to find a better electrical synchrony and clinical outcome. So, I mean, for IVCD, it's a complex, so it's not so easy to confirm when we should add a LV lead or not. And from the previous study, we know hot CRT comes to from 2019 in this paper. It's a quite small scaled study showing that in 27 cases, the highest success rate and the QRS duration can achieve the narrower than BiVP only or Hispano pacing only. And the clinical result seems like better from the baseline during the follow-up. But if we come further to see all these cases, just IVCD cases just account for 5 cases. Most of them are LBB cases. That means if you have LBB cases, you're using Hispano pacing to correct, but after Hispano pacing, the QRS duration is still over 150 milliseconds. That means maybe Hispano pacing is a very, I mean, it's not a corrective LBB cases. At this time, maybe hot CRT should be used to achieve better clinical outcome. So most of them are LBB cases. And the things is similar in this lot CRT paper. Also, this paper showed higher success rate of lot CRT in this kind of CRT in candidates. LVF also increased a lot, and similarly, LBBB cases account for over 40% of the cases, and IVCD just 22%. And from this figure, we know that it is LBBB cases, and with LBBAP, the QRS morphology is quite good, with a narrower QRS of RBBB shape and very short stimulation to LVAT. So in this typical LBBB cases, I think there's no need for lot CRT. We're just using LBBAP only, together with the AV delay adjustment to fusion with the intrinsic RBB conduction. Then we can achieve a very narrow QRS duration. No need for LV lead. And from this table, which can still have the IVCD cases in this kind of study population, the success rate is quite low in IVCD case, and also the proportion of IVCD cases just account for 22% of all the study population. So here comes the question is that we know from this small-scale study that the feasibility and the efficacy of lot CRT has been demonstrated to have good clinical efficacy, but they are all include all CRT candidates, not only LBBB case or not only IVCD cases, and they are all just compared to the baseline, but there's no other control group like the BiVP CRT. So whether lot CRT versus conventional BiVP CRT, I mean, who is superior, we still unknown, especially in these IVCD patients. That's why we just have this study published last year, and fortunately it is as editor's pick featured article. Though this is a small-scaled, non-randomized study, we included IVCD cases, only IVCD cases with LVEF less than 35%, and the 31 cases was primary attempt lot CRT, and another 56 cases primary attempt BiVP CRT on the prevalence of physician and the patient's will. So it's a non-randomized study, and at the last, the success rate of both CRT group or lot CRT group is quite high, over 96%. Here is a typical case. We can see from this wide QRS duration, nearly 200 milliseconds, and it's not a typical LBBB case because there's no notch at V5 or V6, and we map his bundle first, and to see with high output there's no correction at all. So we're trying to find the LBB pacing and to have a different transition from non-selective to selective LBB pacing. Though the QRS duration is quite long and quite wide, and also the QRS morphology is not that typical BBB shape because there's still some S wave at the end of V1, and there's still some notch beyond, the V6 and the V5 with a very long stimulation to LVAT. So at this time, we decide to add another LV lead, and the last QRS duration with lot CRT seems like better than selective or non-selective LBB pacing only. So here is the baseline between the two groups. We can see that most of them seems like similar between the two groups, just the procedure time, because we lot CRT cost more time than BiVP CRT only. And here comes the result. We can see the QRS duration from two groups. The delta QRS duration achieves better in lot CRT than the BiVP CRT. And with lot CRT in this IVCD cases, with LBBAP plus BiVP, lot CRT can further decrease the QRS duration. And for echocardiographic response, we can see the baseline of both two groups is around 30% of LVEF. And after 6 months to 24 months follow-up, the lot CRT have a better LVEF than the BiVP CRT group. And for the echocardiographic response rate, for BiVP, just 31% responsive rate, but for lot CRT, we have significantly higher response rate, over 60%. And for the clinical outcome of this 2 years follow-up, we can have better clinical response, and also the lower primary endpoints include mortality or heart failure hospitalization in lot CRT than BiVP CRT. So here comes the summary and discussion. Lot CRT might have better electrical synchrony and clinical outcome than BiVP CRT, though this is a non-randomized small-scale study. And lot CRT might be used in this CSP uncorrected situation. It's like IVCD or non-LBBP cases, or maybe like LBB pacing failure or at this situation. And lot CRT, sometimes, I mean, in these IVCD cases, maybe it is just LVSP plus LV pacing. It's maybe just like what we call multiple site pacing, like MPP or MSP. Because LBB pacing only cannot achieve a better, a complete electrical synchrony in IVCD cases. So here comes the question: when do we need lot? For a clinical practice, maybe sometimes we do CSP first to see to have a his bundle pacing to correct or
Good
not.
news.
If not, maybe we can use doing LBB pacing plus AV delay adjustment.
Time is up so fast.
And where shall we position the lead? It remains unknown, unclear now. So maybe we need more clinical trial to show whether, when or where should we position this lead, and when we need lot CRT. Thank you. Thank you for your attention.